If you could turn your video on, if you're not trapped under a heavy object, that would be wonderful. I'm just gonna wait one more minute.
I actually kept my slides to a reasonable number, so if we want to get started a couple minutes late, I probably should have time to get through everything even still.
I'm just looking at, once it hits 104, I'll get going.
All right, perfect. And since we have a pretty small group, like, interrupt me, we can go into more detail on certain slides. Yeah, the first half is essentially study designs with a focus on smarts and on other comparative implementation kinds of studies. And then the second half, I guess, essentially is more about just pragmatic trial design with a focus on Tracy. So if people are not as much interested in that part, we can either go through that more quickly or whatever. So I'm happy to kind of tailor.
All right, well, I'm going to give you an intro, JD. So JD Smith is an associate professor in the Department of Population Health Sciences at the school at the Spencer Fox. Is it S? How do you pronounce that last one?
Eccles.
Eccles School of Medicine at the University of Utah. He directs the Dissemination and Implementation Science Core of the Utah CTSA, directs Methods and Implementation Science Cores in 4 other NIH-funded centers. He directs the Health Behavior Intervention Implementation and Translation Core at the University of Utah Diabetes and Metabolism Research Center, is an MPI co-director of the CIRCL Chicago Implementation Science Center, funded by NHLBI. There's too much, dude. He's on the faculty of NIH-funded implementation science training programs in cancer, HIV, and mental health, and is a founding co-director of the Mountain States Partnership for Community-Engaged Dissemination and Implementation Science Training Institute. His research has been supported by the NIH, CDC, AHRQ, HRSA, USDA, and foundations. He serves on several national committees and advisory panels on implementation science and is the associate editor at the Journals of Implementation Science, Prevention Science and Families, Systems, and Health. Previously, he was an associate professor in the Feinberg School of Medicine at Northwestern University, where he was the associate director of the NIDA-funded Center for Prevention, Implementation, and Methodology for Drug Use and HIV, and the co-director of the Program in Dissemination and Implementation Science in the CTSA. And without further ado, I'm going to pass the baton to JD.
Thanks so much. Really appreciate this opportunity to speak with you all. Yeah, and as I already had mentioned, if anybody joined here very recently, happy to kind of tailor this presentation to what you all are interested in. Since we have kind of a small group, we should definitely dig into things if we want to. And yeah, I can be very flexible. So we do have a little bit of a focus on pragmatic and smart trial designs today. I will cover some other trial designs for implementation research, but that is the main focus. As everyone knows, probably, today is the 35th World AIDS Day. I just wanted to obviously recognize that and, thank everybody for their contribution to ending HIV, whether it's domestic or global. So the goals for today, we're going to go through the defining characteristics of trials to test implementation strategies. Hopefully help the folks gain an understanding of smart designs for testing implementation strategies. Understand pragmatic trial design principles as applied to implementation research, and then hopefully gain an appreciation of some of the key challenges in designing and conducting pragmatic implementation trials. But again, we may not get to all of this, so totally fine if we don't. So just some kind of big picture. So when we're talking about designs for implementation research, we are typically talking about studies kind of two different areas. One is sort of implementation preparation, and we'll go into this a little bit more, but these are what I kind of view as studies that are in preparation for a test of implementation strategies. Some of the things that we can answer are how evidence-based programs are adopted, scaled up, and sustained in community or service delivery systems. And of course, some of the bread and butter of implementation research trials is to evaluate the impact of implementation strategies really on implementation outcomes like adoption, adaptation, scale up, sustainability. And that was pulled directly from NIH's Dissemination, Implementation, Research, and Health funding opportunity announcement. So that is kind of how they define implementation research, and especially as it relates to science. Hendricks Brown and colleagues published a paper in 2017 in ARPH that really talked about kind of 4 classes or 4 types of study designs. The one we're going to talk almost exclusively about today is randomized and non-randomized designs. However, there are obviously hybrid effectiveness implementation studies. There are more kind of quality improvement type designs that are used to generate local knowledge, but are not necessarily intended to have generalizable findings. And then there's kind of a newer class that Hendricks had put forth about simulation modeling. And this could be, you know, agent-based modeling or statistical simulation, lots of different kinds of simulation models that can help us prepare for implementation research, but in and of itself, you know, is, again, it's simulated. So, okay, so implementation preparation research, this was defined in a paper in 2019 that was published in AIDS and Behavior, where we did a review of what it ended up being a mapping review of funded domestic HIV and implementation research studies, and having coded all the studies for sort of the study designs they were using, the types of research questions they were asking, and what kinds of aims, we were able to categorize sort of a, you know, not an exhaustive list, but a pretty representative list of the types of implementation preparation studies. So again, these are kind of studies that you might do in preparation for a full test or evaluation of implementation strategies, but this should sound very familiar. So we often do studies to understand implementation barriers and facilitators, potentially implementation processes. We explore the feasibility and acceptability of novel strategies, and novel just meaning a strategy that's new to a particular context. We often do studies to develop or to tailor or select strategies to align with specific you know, implementation barriers or determinants. We often also adapt evidence-based interventions and then pilot test. And so adaptation in and of itself is an application of an implementation strategy. But we, you know, sort of have to do that adaptation work and pilot test prior to a full-scale or fully powered implementation trial. And then kind of consistent with the last slide, we found a number of studies that looked at simulation or statistical modeling that has the potential to inform implementation research, but in and of itself, you know, is not an actual test. It's an in silico test. So some of the common methods that people use for this type of research is field studies, observational studies, you know, CBPR, or any number of kind of community engaged research paradigms, dynamic systems modeling, simply things like surveys and key stakeholder interviews or focus groups, and then all sorts of pilot studies with varying, you know, study designs. But what we're mostly going to talk about today is is randomized and non-randomized trial designs. So most of the stuff that's on this slide is less applicable to actually fully testing implementation strategies in randomized and non-randomized designs. So just to get us all on the same page, when we talk about design terminology, in the context of this presentation, design refers to the planned set of procedures to do 3 major things. So one is to select subjects or larger units for a study. The procedures to assign these subjects or units to or measure their naturally chosen conditions. And then procedures to assess and measure outcomes before, during, and after assignment in the conduct of the study. We won't talk very much about this piece, about measurements. We might get a little bit into what kinds of outcomes, but you know, really we're talking about the first 2 bullets today. So there are a number of characteristics and challenges of implementation studies and trials. Sorry, my dog is very interested in the FedEx band. So a couple of characteristics of implementation studies and trials that differ particularly from clinical research studies. So one is that we really have a slightly higher value on external validity compared to internal validity. It doesn't mean that we don't care about internal validity, but again, in the context of an explanatory trial versus a pragmatic trial, the explanatory is really only about internal validity, and a pragmatic trial is going to have at least balance between external and internal. But in comparison to most clinical trial designs, we are much more on the external validity side. One of the principles, too, of doing any kind of implementation trial design is to try to minimize disruptions to and burdens on our partnering delivery systems. So, really asking a healthcare system to drastically change its workflow, or to infuse a bunch of resources and processes that really are not consistent with their current way of doing healthcare delivery is potentially going to be very difficult and overly burdensome. So trial designs that really are kind of, as minimal burden as possible are critical. And then in the context of randomization, in most implementation studies, randomization is going to occur at higher levels of the service system, like providers, clinics, counties, World Health Organization, the World Health Organization and the World Bank have actually done country-level randomized studies of implementation as well. So it doesn't mean that there's no place for individual level randomized trials, but for the most part, when you're testing implementation strategies, and that's really support for providers and systems, you're going to have, kind of higher level units that need randomization. The consequence of this is that we often end up with a small number of units in comparison to more typical clinical trials. You also end up with nesting within multiple levels of the system. Whether or not you're randomizing at multiple levels is sort of irrelevant to this point, because even if you randomize at the clinic level, you're going to have providers within clinics, you're going to have patients within provider groups and within clinics itself, and then those clinics may be part of like larger health systems or jurisdictions, depending on the nature of that delivery system. So by the very nature of this work, you're going to be randomizing at something that has probably something above it and something below it in terms of levels, and having to deal with some of that nesting. And of course, you have lots of interactions between these levels that often have to be accounted for in the design and analysis portions. When we talk about experimental designs or quasi-experimental designs, your implementation strategy or strategies tend to be the thing that you manipulate as the independent variable, okay? And you'll see some examples where we manipulate the strategy, and there's multiple arms, but the intervention, the underlying EBI, is held the same, so that we really are isolating the effect of the implementation strategy and not getting any sort of confounding effect of different treatments that are offered or different interventions that are offered within those arms. So when you're choosing a research design, everyone asks, well, which one should I use? It's a pretty simple answer that I think sometimes gets lost. It's your design should help you answer your implementation research question. I was at a presentation a couple of weeks ago with Danny Almiral, and if you guys know Danny, he does some really awesome novel trial designs like SMARTs, Maisies, these really cool adaptive designs. And he said one of his biggest pet peeves is people saying, "Hey, I want to do a SMART," and he's like, "Why?" What? And he really, going forward and saying like, "I want to do a particular kind of study design just because it's cool," is probably the wrong way to go about it. It's more about, do you have an implementation research question, and then what does that align with? What type of design is needed to answer that question? So don't start with design, start with research question. When you're actually thinking too about more specifically which design to use, consider at what level in the system your primary outcome is measured. And this often or almost always should align with the level the strategy is targeting. So if you have a behavioral intervention that's being delivered and you in your preliminary work really figure out that the problem that you're not able to achieve the best clinical outcomes is because of low fidelity, you may do an intervention with strategies that target provider fidelity of delivery to that intervention. And so in that case, you're likely going to have randomization or assignment of either individual providers or provider teams, depending on how they're organized within a healthcare delivery system. And then you'll be using implementation strategies targeting fidelity. And so that you can kind of see that all those line up versus a more like organizational level strategy that likely is going to need an organizational level assignment and then an outcome that is an organizational outcome. It wouldn't make a lot of sense to do an organizational implementation strategy and then to measure individual provider level outcomes. One question you always have to ask too in the initial process of identifying a research design is, do you have sufficient units to answer your implementation research question? Okay, so this is often a issue of power, but it can also be just an issue of having sufficient data for, having really good outcome distributions. Okay, so if you have a really small sample or small data set, you may have outcomes that highly vary, and so you'd have less confidence in those. So having a high number of units is really necessary in some of these cases. Another question you have to ask is, can you randomize the units? And this is really a question that you have to address in partnership with your healthcare delivery system partners, or if you work with schools or community-based organizations. Is it actually ethical? Is it acceptable? And is it feasible to randomize units? And this is where we get into some non-randomized or potentially some restricted randomized designs. But in most of the situations we'll talk about today, we're assuming that randomization is possible because it's a lot more complicated when you can't randomize. So we're kind of going with best case scenario today. And then another question too is implementation as usual an acceptable comparison? Okay. Meaning, is it okay for some of the people who are going to participate in the study to essentially not get a lot of implementation support? They just do the implementation as they normally would, and they get evaluated. Is that something that those partners are willing to be randomly assigned to? So in kind of breaking down even more deeply the types of trial designs or types of study designs that you can use in implementation science, most of those implementation preparation studies are really considered like formative and developmental research designs. So we've already talked a little bit about those. We also have some non-experimental designs that can be used, and there's really good examples of these in the literature. So some observational studies or some interrupted time series designs of like policy implementation. So you can't, when a country or a jurisdiction is going to roll out a new policy, it's unlikely that they would allow you to, or that it would be feasible to randomize, the folks who are impacted by that policy to different conditions. And so we can study those observationally or through an interrupted time series design with, some caveats around internal validity and causal interpretation, but still ways we can actually still evaluate those things. More commonly, especially in sort of small or preliminary or pilot type studies, people will use it within site design. So within site designs are, post designs, pre-post designs, or interrupted time series also applies here. These are generally quite simple designs. They're typically not randomized because you only have one site. And you typically are comparing your implementation strategy to either pre-implementation, so prior to introducing the implementation strategy, or potentially to no implementation. And you can imagine that in certain situations, I'll try to think of an example. So if you were trying to do HIV testing within dentistry practices, okay, which is not totally out of the realm of possibility, there is no pre-implementation because they're not doing it now. So by the very nature of having not doing HIV testing, your pre is going to be 0, okay? So in those cases, we're comparing to no implementation, and that tends to end up being a post-design. More commonly in the experimental design literature, you're going to be looking at between site designs. So these are going to be study designs where we have multiple units. We are going to replicate the effects, hopefully, or aggregate the effects across multiple units that are assigned to different arms, typically in the comparison of different implementation strategies, one of which can be implementation as usual. That is a strategy. It's not evidence-based per se, but it is a strategy condition. In these cases, being able to randomize really does help reduce bias and increase internal validity. And this is kind of the first level of study designs that you could say actually are used to produce generalizable knowledge. The ones above, the non-experimental with insight, those are not as robust. There's too many potential sources of bias. We then also have a group of within and between site designs. So these are things like rollout designs, the broad class of rollouts, which includes stepped wedge, and a trial design that I and Hendrix Brown developed called the Rollout Implementation Optimization, or ROYO design. And all of these kinds of within and between site designs, the units are assigned randomly to the timing at which they're exposed to the new implementation strategy. And they cross over from a pre-implementation to post-implementation that is after the exposure. We also have sequential multiple assignment randomized trials, or SMARTs, that I'll talk about here in a minute. SMARTs are kind of weird. They're kind of like, they have some characteristics of a between site design and some of a between and within site design. So I don't even know where to put them in this taxonomy, but regardless, we will talk about them. So let's jump into a couple of study designs. I'm going to go into a pretty typical type design that is actually kind of unique at the same time. So this is a design for a comparative implementation trial. And my animations are already messed up, but that's okay. So this is a study that Katie Burkle and I are the NPIs of. The study protocol was published in Implementation Science in 2018. And this is a comparative implementation trial that has a within-arm patient-level randomization, okay? So I'll just give you kind of the overview here. So we had multiple clinics that were not randomized to the condition of the implementation strategy. Okay, so some of our clinics were capable of doing one of the strategies and some were not. And so those who were able to do the integrated delivery within their clinic went into that arm, right? It was just, if you're able to do this, that's the arm you're in, because we didn't have a huge pool to choose from. We then had another set of clinics that did not have the capability, did not have the resources, they didn't have personnel, they didn't have the ability to bill for integrated deliveries of services within their clinic. So they used a referral model. Okay, so non-random assignment to the implementation strategy condition. But then within each of those different arms, as individual families were recruited into the study, they were randomly assigned to either continue with services as usual or to get the family checkup for health intervention. Okay, so what this allowed us to do is have a fully powered trial of the family checkup for health versus pediatric services as usual for pediatric obesity and mental health, while also non-experimentally or quasi-experimentally testing the impact of two different implementation strategies, okay? So this is what we would call a comparative implementation trial. We are comparing two different evidence-based implementation strategies and looking at the variation that's accounted for in the intervention effects. So as I mentioned, the overall premise of comparing two implementation strategies in a two-arm study like this is pretty common. The randomization to service as usual versus the experimental intervention is the less common part. Typically, everybody would be given the intervention. And so these two pieces where it says service as usual would essentially just be taken out. And every family that comes through either type of clinic is going to get family checkup for health. The reason that we did the randomized assignment to service as usual is this was the first time that family checkup for health had been embedded and delivered within pediatric practice. And so we needed to have a fully powered trial to show that the adaptations that we did to the intervention for this new context did not have a detrimental effect on the effectiveness of that intervention. Okay, so let's just kind of keep building. So in this particular example too, when you actually break down what exactly did we compare, we have a set of core implementation strategies, and that's what's here in this purple box, that was applied to both arms. So in both situations, we identified kids the same exact way. We trained, provided consultation, fidelity monitoring, and certification processes for the family checkup for health interventionists the exact same way in both arms. So that, again, really helps us isolate the implementation strategy and not some other implementation strategies here, but really those two that are related to the service delivery model. We also have the exact same intervention. So family checkup for health, components and content were exactly the same in both arms. And then randomization to service as usual happen after assessment, the baseline assessment within organization, again, to really have a bona fide full test of effectiveness. In the integrated co-located delivery arm, this is where we start getting differences between the two arms. So for this arm, we actually trained existing behavioral health staff to deliver the family checkup for health. We had community health workers conduct the assessments. This is an assessment-driven intervention. So somebody has to assess the families at the very beginning or at enrollment. And then delivery was predominantly through home visiting, but obviously they were also able to do in clinic because it's a co-located delivery model. In the other arm, where they were referring to external providers, we actually hired behavioral health staff who were study employees to serve as that sort of external referral pool of providers. We had undergraduate students conduct the assessments, and undergraduates have similar type of education as community health workers. So that was a fairly equivalent kind of staffing there. And then delivery here was, again, predominantly home visiting, but because this was not part of a clinic, we also offered the service for meeting with the family in a community setting. So you can see some of the differences there, but that was the comparison that we had. Okay, let's jump into SMARTs. Actually, any questions about this study before I jump into SMART? Okay.
I would just say it's an interesting assumption that the undergraduates can be trained up to replace a CHW.
Yeah. Well,
so
I agree.
I mean, that's just an observation. I understand.
No,
and the reality that if you really wanted an external provider, they would need to be embedded in a system. And so it's an interesting choice to basically create a sort of, I don't know, best possible controlled external provider, as opposed to a real world external provider where you'd need, you know, a community-based organization that had CHWs.
Yep. So two things about that. I agree with you that there really isn't an equivalence of the undergraduates with community health workers for the whole realm of things that CHWs do. But because this was really only for doing the assessment, it was relatively consistent. Your other point, though, is really well taken and actually gets a little bit into the pragmatic design principles. So the co-located integrated delivery, highly pragmatic. So this hits the majority of the high pragmatic ratings in the PRACY2 tool. The referral to external provider, because these were study employees and because they were working sort of outside the context of a delivery system, as you mentioned, would be a much less pragmatic study design choice. So yeah, very good points. So jumping into SMARTs. So SMARTs are sequential multiple assignment randomized trials, okay? So the purpose of SMART designs is to optimize the optimization of dynamic and adaptive multi-component implementation strategies. And you have, the assumption here is that you have to have at least two, but typically more than two implementation strategies. And you'll see in the examples how that plays out. So there are kind of two major types of SMART designs. One is called a restricted SMART, and this is what you'll see most commonly in the literature. There was a systematic review done, I think published in 2021, that looked at SMART designs. And they found that it was only about 15% use an unrestricted SMART design. So about 85% were using the restricted, which was kind of the original, and the unrestricted is a variation. So the restricted SMART design allows implementation strategies to be evaluated while responding to clinics or recipients' failure to reach impact, okay? You'll see that in the examples, but essentially this means there's a response non-response mechanism that is built into the trial design and taken into account when assigning to implementation strategies after the first randomization, okay? In an unrestricted SMART design, this allows you to test the implementation strategy combinations and their sequence effects regardless of the response to the initial implementation strategies. So let's take a look at some examples. So here's a restricted smart design. This is a purely hypothetical example. You'll notice there's no citation here. This is one that we use just for illustrative purposes. And so in this particular example, the research question really is for primary care clinics that are starting to or are looking for basically trying to improve how many of their patients get on pre-exposure prophylaxis. There's two major ways of doing it. This is very similar to the prior study that I talked about. So one is to actually do kind of the typical model of referring to a PrEP provider, right? Referring to a specialty STI HIV clinic where people are very highly trained, very knowledgeable about pre-exposure prophylaxis. And a lot of primary care providers actually prefer this model. So the other option is to actually train primary care providers to do in-house PrEP. So they do the identification, determine eligibility, actually do PrEP prescribing, and then of course do all the necessary guideline adherent follow-up care. So you can imagine, again, especially in the early days of PrEP, maybe less so now, there might be some reluctance to do in-house PrEP. Maybe there's actually even, on the patient side, there's more acceptability to do referral to an external provider who maybe is less stigmatizing. You can make some assumptions here. But in this particular smart design, the primary care clinics that you recruit can be randomized initially here, that's the R here, to either the in-house PrEP or the referral to an external PrEP provider. In a restricted smart design, there's a period of assessment that happens at basically here. You determine whether or not there has been a response or non-response to the implementation strategy. So just following kind of the upper pathway here, for clinics that have actually done really well with in-house PrEP prescribing, and we would consider that as like high uptake, high adoption, high reach, something like that, however you're going to define that, they just continue, right? There's no reason to kind of mess with it if they've already shown that they're responding. For those who have not responded, which we might interpret as low uptake, low adoption, et cetera, that particular subgroup is now re-randomized to, in this particular case, to get additional provider training. So maybe it's just an issue of actually not having been trained as well as they could have been, or potentially we need to actually see if they would respond or be better if they just referred, okay? So we can cross essentially these two implementation strategies. And you'll see on the lower half, we basically have a mirror of the exact same process. So when there's high uptake to the referral to external PrEP, they simply continue. Those that have low uptake get re-randomized to the provider, the additional provider training, or to the other original arm of in-house PrEP. The one thing that's really challenging, actually there's two really challenging pieces of a restricted smart. The first is really the determination of what is considered response versus non-response. And that has to be determined up front. That has to be an a priori decision about what is the threshold for having to being considered a responder versus a non-responder. And then the second kind of embedded challenge within that is then evaluating and assessing that response data. Okay, so being able to actually get very valid and reliable response data to be able to determine this high versus low uptake and the non-response response mechanism. You can imagine if this data needs to be essentially quickly available, otherwise this period of time here before re-randomization ends up being very lengthy and can make your actual implementation of the trial very difficult. So that's one of the main challenges of this type of design. Okay, the other main challenge actually too, and this gets into more of the statistical analysis, you can imagine that you get a lot of people who have high uptake, and that means your subgroup that gets re-randomized due to low uptake becomes very small. And so thinking about sort of a factorial type, mental model of this, that means you end up having a cell that's very small or a couple of cells that are very small within this type of design. So that's where, again, if you mistake in some way the response non-response mechanism, you can cause yourself some challenges in the analysis portion. So let's look at okay, so this is about as simple of a restricted smart design as you can possibly do. Again, this was a totally made up example, but is certainly within the realm of possibility. Here is a much more complex restricted smart design. And this one is actually one that's led by one of my good friends and colleagues here at the University of Utah, Dave Wetter. And this is a restricted multi-level 3-phase SMART. So you can see 3 different randomization points that actually happen again at multiple levels. This particular study was about tobacco quit lines and getting people connected to tobacco quit lines. They were going to be conducting this trial in 33 community health center clinics that were actually within 11 community health center umbrella organizations, but it's 33 locations of care with an expected or target enrollment of about 6,000 tobacco users. So in this particular case, again, just looking at how complex this gets, you have randomization to 2 different implementation strategies here, which is the Ask, Advise, Connect opt-in approach versus the Ask, Advise, Connect opt-out approach. And then there's a response, non-response mechanism. If they do well, they just continue and they're done. Okay, and that happens down here as well. If they are doing well with the opt-out, they just simply continue and there's no re-randomization for those clinics. For those who have a non-response, there's randomization again. So very similar to what we looked at on the previous, you can see all of the kind of mirroring and parallels on the upper half versus the bottom half. They get re-randomized to text messaging or to continued AAC. And then again, the response, non-response, if you're doing well, you continue. If you're not, you go here, and then your no's, you get re-randomized again to this additional implementation strategy. Okay, so fairly complicated, but you can see that there are numerous published SMART designs that look very similar to this. This is a complicated one, but it is not like a super unique design. Not surprisingly, the lead biostatistician for this project is Billy Nalamchani, who's one of the top 3 or 4 most well-known people in the country for SMART designs. So still, it's a complicated design, even if it is not totally unique. So pretty cool. Let's look at an unrestricted SMART that's in the literature. This was published by Aaron Schoenfelder in the Journal of Child and Adolescent Psychopharmacology. And this was a study for kids with ADHD, if I remember right. It was looking at behavioral parent training versus maternal stimulant medication. And in this particular study, you can see there's only, this is actually the only, there's 2 randomization points, but there is no response, non-response. So you remember those in the previous example, we have the response, and then if you respond, you just continue and nothing else happens. You don't have that in an unrestricted. In an unrestricted, everyone's going to get randomly assigned once, and then everyone's going to get randomly assigned again to something else. And so in this particular case, they are essentially doing an additive approach and looking both at the addition of new strategies and you can look at sequence effects here. So you can look at whether you do behavioral parent training first and then do the boosters or then do the augmented. But yeah, it's a pretty cool design if you have a really good idea about different combinations and different sequences of implementation strategies. It's better designed for that than the restricted SMART that would have a number of clinics just not ever get re-randomized because they responded. This one also takes out the response, non-response mechanism challenge, right? Both in measurement and in definition of what that response mechanism is. The ultimate, kind of outcome of this, even though the figure here is kind of obscures this a little bit, but essentially you end up with 4 treatment sequences. You end up with this MSM to MSM, MSM to BPT, and this is not the MSM we typically think about. It's the maternal stimulant medication. But you end up essentially with more or less a factorial design that incorporates sequence effects, okay? So let's actually take a look at an alternative, which is a factorial that does not have sequence effects, just to give you a sense of what an additional option is. So again, this one kind of ends up looking like a factorial, very similarly anyway, but has those sequences. So this is a trial that we call PREVAIL. This was funded in the last few months. PREVAIL stands for Primary Care Evidence-Based Approach for Improving Lifelong Health. And this is a cluster randomized multi-level 2x2 factorial design that was funded by NHLBI to Katie Burkle and I again. So just a little bit of background about why we chose the type of study design that we did. We encountered a number of implementation barriers in 2 prior trials of Family Checkup for Health. One is that it's really time consuming and there's uncompensated preparation work within our model that made it really challenging for people in real practice to actually do this because it was hours that they couldn't bill. So, and this really impacted reach. So we came up with an implementation strategy of doing an EHR integrated clinical decision support that would essentially drastically reduce the prep time for the providers of this assessment-based intervention. In terms of the effectiveness, you know, families that engage in the FCU for health, there is variable engagement, okay? And most of that is variable engagement in individual sessions, but also in what we call home practice assignments, which is, as it sounds, assignments that we give at every session to try new parenting skills in between sessions. And so we came up with an implementation strategy in partnership with our healthcare system that we work with and with the parents that had participated in our prior trials, that a tailored SMS text messaging intervention that would promote competent home practice between sessions and encourage their engagement may improve the total engagement in the intervention and thus increase the overall effectiveness that we see of the family checkup for health. The other problem that we noticed is that in most of the systems we've worked with, there is no practice of ongoing fidelity support. So they don't track fidelity, no one's assessing fidelity. They just, you know, potentially have some supervision, but it's not really, you know, fidelity monitoring like we would think about it. So we partnered, or at least engaged, a company called Listen.io, which is Dave Atkins, Sri Narayanan, and some other folks, that developed an automated fidelity monitoring and feedback system for motivational interviewing, which is central to the Family Checkup for Health. And you know, deficiencies in MI would be indicative of having low fidelity to the intervention. So those were our 3 implementation strategies that we proposed, and you can see what we were hoping to achieve as a result of these strategies. So in this particular design, we, in partnership with our health system, they basically said, if we don't have the clinical decision support to reduce that uncompensated prep time, it's not going to work. So the CDS tool became a non-randomized implementation strategy. Everyone's going to get it. It's just because it is really necessary. But that leaves us with a 2x2 design where we can test the automated fidelity monitoring and feedback at the care team level. And then we can test this tailored SMS text messaging implementation strategy to increase engagement for families. So that's why this is a multi-level 2x2 cluster randomized design. So the actual design is 12 behavioral health care teams that have about 12 to 14 clinicians in each team. So we'll be training and randomizing a total of 150 clinicians among those 12 behavioral health teams. So we have basically 3 care teams per cell. All youth age 2 to 17 that are in behavioral health will go through the family checkup. Whether or not they consent to the intervention or not, or consent to the research or not, is actually going to become standard of care. And we anticipate having about 1,200 consented and a little bit more than 2,000 total families that are likely to actually get the family checkup for health during our project period. So in contrast to the previous restricted smart design, unrestricted smart design, where we had sequence effects, there's no potential for doing sequence effects. We still have 4 conditions where we can look at, but there is no temporal relationship between any of these. They are, if you're in the yes/no condition here, you get this. If you're in the yes/yes condition, you get it simultaneously. There's no time component like there is in this particular design where you can look at the actual sequence of the different implementation strategies. So those are just some examples of different kinds of smarts and factorials and some of the pros and cons of each of those. Okay, so this is our transition point into pragmatic trials. I realize we are 40 minutes in. Are there any questions about these smarts or factorials that we want to talk about, or do we want to jump into pragmatic?
I guess just jump in.
All right, so I'll go through this fairly quickly. So what are pragmatic trials? And I do want to acknowledge that most of the slides in this section were courtesy of Wynn Norton. She and I and a couple of other folks presented this work at last year's D&I conference in DC as part of a pre-conference workshop. So some common descriptions. What do people say a pragmatic trial is? So people say pragmatic trials are trials that are conducted in the real world, that they're conducted in healthcare systems, that they're conducted in partnership with collaborators or stakeholders. Sometimes people assume that pragmatic designs are non-randomized trial designs, which is not true. That they are effectiveness trials, essentially the idea that if you're doing an effectiveness trial, it's by its very nature pragmatic, and the same thing for implementation trials. All of these things are basically wrong for various reasons. You can do a trial in the real world that is actually less pragmatic, and you can do implementation trials that are absolutely not pragmatic. These are just some assumptions that we probably should not be making, but this is what the literature shows people assume or sort of conflate pragmatic designs with some of these other characteristics. So here's a quote that I pulled from a paper on pragmatic studies that I think is really helpful. So they said here that basically there's a lot of use of the term pragmatic, but the people are very unspecific, or there's a lack of specificity about what actually makes their trials pragmatic. So this was a conclusion of a systematic review where they said many pragmatic RCTs have some clear explanatory features. And explanatory is the opposite of pragmatic when you're thinking about the pragmatic explanatory continuum that I'll talk about in a second. And some of these features were, they were single centers, they were double-blind trials, they were placebo-controlled, and they provided incentive for participants, which are not pragmatic features, right? So the authors of 45% of the articles did not justify or discuss the claim that their trial was pragmatic, and many other justifications were simply just rudimentary. So the term pragmatic was often actually in the title, which they thought was attractive to readers and policymakers, but the inclusion of this term did not actually guarantee that they applied pragmatic trial principles. So this was really the state of the literature, 5 years ago. I don't think it's changed too much in just my own experience with reviewing manuscripts and reading, a lot of published papers. So how do we conceptualize trials along a continuum? So I already kind of mentioned this explanatory to pragmatic continuum. Every trial exists on this continuum, and many features of trials have to be broken down on their explanatory pragmatic continuum as well. So let's go through some of those. So in an explanatory trial, what is the purpose? So an explanatory trial is trying to understand the effects of an intervention. These are typically called efficacy trials. Many of them are delivered under more laboratory conditions. They're intended to maximize internal validity, and there's less concern with external validity, which I kind of already touched on a little bit. The purpose is to confirm or disprove that there's a causal mechanism connecting an intervention and an outcome. Okay, so we're really this is very mechanistic, very tightly controlled kind of trials. And the key question is, can an intervention work under ideal conditions? So we're going to really, sort of highly train individuals to deliver the intervention. We are going to have very narrow inclusion criteria so that we don't have potential, confounding effects or sources of bias. And we really just care about, does the intervention affect the outcome as we hypothesize? In a pragmatic trial, these are really intended to help with decision-making of actual service delivery entities, whether that's policymakers, healthcare system leaders, individual providers. It's about helping to inform decision-making. We often call these effectiveness trials, again, in contrast to efficacy trials. They are delivered hopefully under more normal or real-world conditions, and there's an intention of balancing internal and external validity. The purpose here is to assist decision makers in choosing an intervention that's going to work in their system. And the key question is, can the intervention work under more usual or real world conditions, right? So here is a little comparison of what you might consider an explanatory attitude versus a pragmatic attitude. So an explanatory attitude would say, my study is aimed at understanding causal relationships between an intervention exposure and an outcome. In a pragmatic attitude, I would say that my study is aimed at helping others to make a decision about best available intervention. An explanatory attitude would be, does the intervention cause a different outcome? Pragmatic would be, which intervention should we use, or which one is preferred to achieve a specific outcome? So you're getting into a little bit more comparative effectiveness, some of those kind of questions too. And you can see here some of the kind of different questions that you would have. I'm going to skip through that just for time. So when you're designing trials, it really needs to be done to fit an overall intent and purpose. And so really asking yourself, what is the purpose of this trial? Are we really just interested in determining whether or not the intervention achieves an outcome? Or again, is it more on that decision-making side about what is the best intervention for my setting? And what question are you trying to answer and why? So that goes back again to those different intents and purposes of explanatory versus pragmatic. And then asking too, for whom will the results be applicable? And back 20 years ago when I was in grad school, and we talked a lot about efficacy trials not translating to the kinds of information that people in the real world need. That's the question here. Is this result going to be applicable to anybody out in the real world, or is this just, really to inform future research, right? How will the results of the trial be used? Again, is it for future research, or is this actually to help decision making in real systems? And you want to align the answers above with the design of your trial to fit along the continuum as intended. So let's get into some of the elements of these trials. So this comes from the Précis 2, but the 9 elements or 9 design elements of trials in general that you can place on a pragmatic to explanatory continuum are the eligibility criteria, the approach to recruitment of participants in a trial, the setting in which the trial is conducted, the organization that actually does the service delivery, the flexibility afforded to the person delivering the intervention, the flexibility in their ability to be adherent versus non-adherent. What is the follow-up, both duration, intensity, and type of data that's used for follow-up? And then what is the primary outcome of the primary analysis? So in that case, the primary outcome is really, are you looking at something that is, let me give an example. So if you were going to be looking at an HIV treatment approach, you may, in an explanatory trial, be actually taking blood and doing CD4 counts. Okay, in a large health system or a large pragmatic trial, that is not possible and would not be the type of outcome you would do. You may be looking at just surveillance data of new HIV infections, and the assumption would be that if you're able to reduce CD4 counts at a population level, you would reduce new HIV infections because everyone would be undetectable and, of course, not able to transmit HIV infection. And then primary analysis in this case predominantly refers to whether this is a full intention to treat analysis versus a more per protocol, or where you might throw people out for various reasons, like low fidelity of delivery, or potentially because they had a comorbidity was discovered halfway through the trial, and we're going to throw that person out, versus all data counts. We're going to look at how everyone was affected regardless of some of those pieces in an ITT type of paradigm. Okay, so on the Précis, so Précis stands for Pragmatic Explanatory Continuum Indicator Summary Tool, and this is version 2. So you can see all of those exact criteria, or all those elements that we just talked about, the eligibility, recruitment, organization, etc., all the way through. In the Précis 2 indicator tool, they provide guidance on essentially coding or rating each one of these different dimensions on the continuum from a 1 to a 5. And in the coding scheme, essentially, the more pragmatic you are, the further you are away from the center in the wheel, and the more area essentially that ends up under the curve when you actually do your ratings and then connect all your dots, the more pragmatic your trial is. There are examples too, as you can imagine, where 6 of these 8 elements are highly pragmatic, but then you have 2 that are not. And that still would be considered a more pragmatic trial. But this is where the Précis 2 really helps address that concern that we saw in the systematic review of pragmatic trials, of people actually getting into very specifically what makes this trial pragmatic versus not. Okay, so I could say, like, I'm going to have very flexible delivery, I'm going to have very flexible adherence. However, for the purposes of whatever, satisfying my funder, availability of data, whatever, my primary outcome might actually be a much more explanatory outcome. And that's okay. Like, it's still a predominantly pragmatic trial. However, we have an explanatory type primary outcome. So that's where Précis is really nice to be able to get into that detail about exactly what features are pragmatic versus not. So pragmatic implementation trials. So, here's some of the normative assumptions that are not always true, is that all implementation research is pragmatic. That is not true. Implementation research is done in the real world, therefore they're all pragmatic. Also not true. Implementation trials are messy and you don't want to control for everything, so you conduct pragmatic trials. Don't ever say that. Yeah, there's a definite pet peeve that people think like, hey, my trial's pragmatic, that means I don't have to, kind of do the same things we would typically do for a well-controlled trial. It's not an excuse to be kind of messy in your methodology. So yeah, all these things are essentially not true. And so basically, if there are selection biases, etc., I'm going to skip through some of these, but I'll send out the slides. Yeah, so here's really one of the key questions, I think, and this goes in, again, is your study really trying to inform decision making about implementation strategies, or is it to understand causal mechanisms? So there's a major shift right now, or at least an emphasis in understanding mechanisms of implementation strategies. And so there may actually be a corollary choice to have a lot more explanatory implementation trials, because the intent may be to understand causal mechanisms. We'll see. But if that is your intent, you're probably looking at a less pragmatic trial and a more explanatory trial to actually look at those mechanisms. So can you conceptualize implementation trials along the continuum? Yes, you can. So this is Wynn Norton and colleagues' paper that is the Précy 2PS. PS stands for provider strategies. So implementation strategies targeting intervention delivery people, whatever type of agent that is. Very similar kinds of things here: eligibility, recruitment, and instead of organization, they call it setting. Here's where we get into a new thing that's specific to implementation trials: is what resources are needed to deliver the provider-focused strategy. So the more resources that you provide, the less pragmatic it is. The more that are actually provided by the healthcare delivery system, the more pragmatic, okay? Also, you get into the flexibility of provider strategies, flexibility of intervention. That's very similar to Précy 2. And then data collection, primary outcome, and primary analysis are also very similar to Précy 2. But this is a really nice tool if you're trying to apply it to an implementation trial. So here's some of the Précy 2 domains. I'm going to, again, kind of skip through these pretty quickly, since they're on the previous slide, and I'll be able to provide these to you all. So in summary of pragmatic designs, there are various ways to conceptualize what it means to be pragmatic, especially in the context of implementation trials. It's really important to be explicit about what specific aspects of an implementation trial are more or less pragmatic, and the rationale or justification for each of those design choices. So I'll give an example. So we, in our initial submission of the PREVAIL study to NHLBI, we were not planning to collect body mass index. We were planning to actually use self-reported health behavior change and dietary change, which is very common in explanatory research. But in most explanatory studies, they also want you to collect body fat mass, BMI, that kind of stuff. We had proposed not to do that. And when we got reviewer feedback, they said, no, we really want you to do that. So unfortunately, because of reviewers, darn reviewers, our trial became less pragmatic. So a very reasonable reason why you would have to do that kind of outcome analysis or that outcome measurement, but having that justification or rationale is important. The other thing that's really important for any evaluation of what is pragmatic versus what is not is that you need to really understand what is implementation as usual, because that is your comparison for all of the 1 through 5 scoring on the Précy wheel, okay? So whatever is considered more pragmatic versus less pragmatic is always in relation to what does implementation as usual look like of this kind of intervention. And so in all of these kinds of studies, you really need to know what that looks like. And so you have to assess and track it, right? So especially if you have a parallel, cluster randomized trial in your implementation as usual condition, doing a really good evaluation of what it means to be implementation as usual is going to help you determine and score your pragmatic versus explanatory features of the study design. Okay, that was all I had. Actually stayed in time, that's good.
Thanks, JD. I know that we are going to split off because you have one consultation with somebody, but before that, is there any burning questions for JD? like you said, we'll get the slides and we're also going to post the lecture on our website so that anybody in your group that didn't have a chance to join can still get a chance to watch it. All right, hearing none. Hina, do you know you have the link to for the person who's going to get the consultation and for JD?
Yeah, they should both have the link.
Okay, brilliant. All right, thank you guys so much, JD. Thank you very much.
Yep, of course.
Thank
Happy to do it.
See you in a week or so.
Yeah,
you.
awesome.
Bye.
Safe travels.